So thanks everyone for coming to Schulich Heart Program Grand Rounds. I'm really happy that we have a speaker from Europe today to come to speak to us. This is Jan Steffel. He's just amazing kind of physician. So he's a professor of cardiology at the University of Zurich, Switzerland, and a senior consultant in invasive electrophysiology and cardiac devices at the Heart Clinic in Zurich. He's board certified in internal medicine and holds certification in both invasive EP as well as cardiac devices. So Jan is involved in multiple education programs. He's involved in many trials. His really primary focus lies on the field of anticoagulation for stroke prevention and atrial fibrillation, as well as novel techniques in ablation and cardiac device therapy. This is just a really tremendously hot topic. So he's been the first author of the 2018 and 2021 European guidelines on use of DOACs, and then chair of the EHRA education committee. So thanks a lot for coming. There's so many people interested in atrial fibrillation and DOAC now. We talk about it all the time, and so this is the chance for us to learn a bit more. So thanks a lot, Jan, for doing this today.
Well, I'll have to thank you, first of all, for the very kind introduction, and then obviously also for having me. It's a great pleasure and honor to be invited to your grand rounds. Would have been an even greater pleasure, of course, to be there in person. And I'm not getting fatigued to mention that I'm really looking forward to having this.
Yes.
As long as we don't have it, it's a very good way of staying connected, especially in these important topics. But like we were discussing earlier offline, we almost kind of forgot how it feels like to go to the other hospitals, to go to meetings and everything.
No, for sure. We'd love to see you in Toronto in the near future.
Thank you very much. Beautiful, beautiful city, beautiful country. I've been there multiple times to Toronto. Also, 30 years ago, I was an exchange student in Rochester, New York, so right across the pond, right across the lake, and visited there. I've still got friends down there, so it's a great place anyways. We'll focus today on anticoagulation. Obviously, we could easily fill an entire afternoon with that. A bit of a focus on the frail and older patient population with a certain focus on our EHRA guide, as well as also a bit on the Canadian guidelines. I'm not going to touch on those too much, because it kind of always feels a bit embarrassing when I'm talking about your guidelines. There are people in your institution that have obviously contributed massively to this. So this is not me to be talking about. This is more really to put it a little bit into perspective from the European side, and to jump to the conclusion already. There's obviously much more similarities than there are differences between these guidelines, and I think this is mainly due to the fact that we're all basing them now on evidence mostly, and the evidence is the same. These are my disclosures. And just really quickly, and also that we just talked about it just prior to the to starting today. I usually start this very topic always with this slide here, because it kind of tells us where we come from. We kind of started to take this for granted. All of this wealth of data, both randomized trial and observational data with the DOACs that we have. But it wasn't. In fact, when we take a look at where we come from in terms of data for VKA, this is everything we had in terms of RCTs, right? It was 29 trials with 28,000 patients. This was, of course, Bob Hart's work here. And there were 6 trials with not even 3,000 participants that were included in the trials that investigated warfarin versus placebo. This is where this 2/3 risk reduction comes from that we always cite, or used to cite, to our patients when we told them, look, this is what you're going to benefit from VKA. So first of all, VKA is pretty efficacious. We tend to forget that. It's pretty efficacious. It's not an easy drug. It's certainly not a drug that's not dangerous in many situations, but it's pretty efficacious. So we really didn't think that with the DOACs we'd be able to beat warfarin. And then first of all, and then secondly, we have to admit that the evidence base that we had was actually quite scarce. So 2,900 participants, you probably these days, it would be difficult to have a power calculation with this type of, if only with one trial, with only not even 3,000 participants. So then came the NOACs, and of course, this was a huge paradigm shift. This is, of course, the meta-analysis that you've seen multiple times. My friend Chris Ruff from Boston, who published this in The Lancet back in 2014. It's the high dose of dabigatran, so only the 150 milligrams, rivaroxaban, apixaban, edoxaban, and this is only the high dose regimen, the approved regimen for edoxaban. And you will find another 19% relative risk reduction on top of warfarin. And again, of course, you've seen this and you know these data, but this was everything but for granted. When we discussed these findings prior to the RELY trial back in 2009, none of us anticipated an even bigger efficacy, better efficacy with the NOACs as compared to warfarin. And at the same time, there was no signal in any of the trials for an increase in major bleeding. Now, there was some heterogeneity here in this meta-analysis between the trials, in the sense that high dose of dabi and rivaroxaban came out similar in terms of major bleeding, whereas apixaban and edoxaban even reduced major bleeding. So obviously, we have to be careful with these cross-trial comparisons, right? Because there's obviously, these are independent trials, different endpoint definitions, sometimes a little bit, especially when it comes to bleeding. But ultimately, this is how the trials came out, right? And these were, in terms of evidence, a different league with respect to the number of participants that were included, anywhere from 14 to 21,000 patients per trial that were included. So really substantial, that at the end of the day, obviously this impacted massively on the guidelines, on all guidelines worldwide. These are the European guidelines from 2020. They're a little less than 1.5 years old by now. I had the pleasure and honor of being one of the reviewers of this huge document. And of course, there is a class 1 recommendation, highest level of evidence for NOACs to be the preferred therapy over VKA. Now, there's a small change towards the 2016 guidelines, because back then they still stated in patients newly initiated on anticoagulation. So which kind of took out the patients that were still on warfarin, and let them kind of be. Right now, they actually followed the wording of the American guidelines back in 2019, and also the Canadian ones went into that direction, in the sense that also patients who are on VKA actually should be offered a NOAC, and we come to that in just a second. Especially for those that are not well controlled, so time in therapeutic range less than 70. For these patients, the guidelines give a class 1 recommendation to switch them over to a NOAC. And actually only a 2A recommendation to try and improve the INR. And also that we'll come to in just a second. What's clear, and there's a class 3 recommendation now, antiplatelet therapy is out. So it's not that we may be possible, could be doing it and everything. Really, aspirin, antiplatelet therapy has a class 3 recommendation, clearly a don't do it recommendation. I think we've been overestimating the efficacy of aspirin for a long time, and we've been underestimating the safety issues. Now we're talking about stroke prevention for AF, right? And so that's why I think it's a pretty strong statement, class 3 recommendation. Now about the target INR, because the guidelines, as you've seen, they recommend to switch over to a NOAC if patients are not well controlled, and obviously provided that they have good compliance and adherence. This is Eli Heilig's work from almost 30 years ago. And it really is, I guess, what we have in mind when we think about the target INR, that when once we're above 3, certainly above 4 or 5, your risk of bleeding goes up. When we're below 2, risk of ischemic stroke goes up. But the misperception about this graph is that there is a 0 risk in between, because that is clearly not the case. On the contrary, these are data now from the Aristotle trial, but not of the apixaban, but of the warfarin arm. So these are only warfarin patients here. And you can see that no matter which endpoint you're looking at, ischemic stroke or no matter which bleeding endpoint, the last INR value prior to the event was almost, well, for the bleeding endpoints unanimously, but also for the ischemic stroke, about half of them actually occurred while people were in the therapeutic range. This is not something that happens only when people are outside the therapeutic range. The risk clearly goes up for a bleeding event and also for an ischemic stroke if they're out of bounds. But if you take as a denominator all events that are happening, the majority of events actually happens within the therapeutic range. For intracranial bleeding, this was over 80% of events that happened with the last INR value in the therapeutic range. So therefore, a clear recommendation to go with a NOAC as the preferred therapy, and to actually offer this even to those patients that are on VKA, particularly if they're not well controlled with the INR values. I've shown the randomized clinical trial data. Now, these are backed by a host, really a multitude of observational data. And we have seen a lot of them over the last couple of years for the NOACs that were around first. So basically the bigatran, rivaroxaban, and apixaban. And we now have some good quality observational data. I kind of tend to avoid the term real world data, because that kind of implies that we're doing our randomized trials somewhere on the moon, but really observational data from daily clinical practice. We have that also now for doxaban, the latest of the NOACs, which has also been around for a while now. This is the Aetna AF registry, a prospective registry. So kind of the highest level of evidence in terms of observational data, because they're really followed up. It's not a only in quote unquote medical records search. And the most important outcome from this registry, you can see here, these are the event rates in the Aetna AF Europe and in the European, or not better, the non-Asian cohort of the Engage AF trial. Because ultimately what observational data tell us is if the data from the randomized trial translate into daily clinical practice. We must be very careful in not over-interpreting observational data, because obviously there's no randomization. And once we have no randomization, we can never exclude residual confounding in these data, which I think is important. We're talking about associations, not about causation in this situation. So therefore, the comparator or the comparison with the outcomes of the randomized trials are extremely important. And what we can see here is that in Aetna AF, we saw an event rate which was in the range and mostly even lower than that observed in the Engage AF trial, although the population was actually at higher risk. And that was true both for ischemic as well as for bleeding events. And I think this is the main message from this. Now, of course, there are some snatches, because obviously these patients are not followed as closely as in a randomized trial. So there's a certain risk for underreporting of events, but clearly we have no indication that our data in daily clinical care go completely in the other direction. And I think this is really the main message here from the Aetna AF study, but essentially also from all other observational trials. If you wanted to summarize the results of all observational trials, this would be it. There's no signal that goes completely in a different direction than what we have observed in the randomized trials before. And hence the recommendation. Of course, and just to finish the guidelines part, it's not only about anticoagulation. Now, it's the ABC pathway, which the Europeans have put up, or the ESC has put up in our guidelines, kind of as an easy to memorize mnemonic, what encompasses holistic AF care. Of course, starts with the A, anticoagulation and avoidance of stroke. This is the main driver of morbidity, mortality. This is the main reason also for problems in our AF patients. So this is why it stands first. However, we must not forget about the B, the better symptom control, and the C. And better symptom control is something that I see frequently kind of neglected a little bit, especially when we talk to primary care, not so much with cardiologists, but certainly the primary care field. AF is still seen frequently as a nuisance, something that is there that's not very helpful, but as long as we anticoagulate people, it's okay. Also the anticoagulation is not always optimal, but it's not like that. Patients actually suffer from their AF. They have symptoms, and treating them adequately with drugs, or obviously more and more with ablation, is very useful in a lot of patients, and a lot of them actually that we felt are oligo or even asymptomatic beforehand actually turn out much better subjectively once they're with adequate rhythm control. So definitely this forms part of the larger care, the overall care of AF. And then finally, of course, risk factors and comorbidities. We do not do a good job if we anticoagulate, we ablate the patient, but don't take care of their OSAS and their hypertension, their overweight, and so on and so forth. This is absolutely critical also. And as such, of course, AF care is a teamwork. We all know that. We have to remind everybody else of that, that everybody is involved, and we should and need to take care of all of the players that the patient can benefit from, because obviously it's not for no reason that the patient is in the center of everything, and then we need to orchestrate everything around the patient, around the patient's needs. Now, this, of course, is something that can easily be found almost word by word in your guidelines as well, by the way, which I find a terrific piece of work. And I'm not saying this only because I'm talking to you now. I've mentioned this in multiple occasions across the globe. These are very well written guidelines and very patient centered and also very practical, because again, I'm not going to go through this because you know these much better than I do, but the principle of an integrative approach to AFib care is obviously also a very strong red line that red thread, I should say, that pulls through the CCS guidelines, and rightfully so. So maybe I quickly pause here because I do see that there are two. Anna, this was just you, Dennis. I just saw that there were two.
Yeah, that's my comment. I know Mohammed has a comment and he has to go. Mohammed, are you still here? Maybe not, or maybe it's on mute.
I had to shoot off.
Maybe just let's keep going. Yeah.
Okay, great. Well, but anyways, please, if you have any questions or comments, and if it is really directly related to a specific point that I just mentioned, if you feel free to just jump in or put in your comments into the chat, and then maybe Dennis, feel free to interrupt me at any time. As I said, I think one of the big advantages of the CCS guidelines really is that they are very practically oriented. That's what I really like about them. I should say that our European ones are not, because we're trying to also learn from others. But at least in the past, this was one of the problems, that we were mainly focusing only on the evidence and really attaching not so much importance to the practical aspects, especially around NOAC care. And this is why we at the European Heart Rhythm Association, EHRA, we have put together this practical guide on the use of NOACs. And this is the latest version. We published this in last year, April of last year. I presented it, and you can download this here for free, or from the journal's webpage. And what really this guide is all about is the multidisciplinary team that exactly forms the whole basis of an integrative AF care. We have not only cardiologists, we have hematologists on board, neurologists, anesthesiologists, internal medicine, of course, nephrology, and also allied professionals. So to really have a view of every specialty that is involved, and this is not only with anticoagulation, and to tackle the practical questions that we encounter on a daily basis. And this is the table of content. And I'm not going to go through all of this, obviously, but it's more to show that we're starting at comparatively easy things like how to switch patients, what to do if somebody forgets a dose, and then go into the more challenging ones like post-PCI, what to do if somebody comes with a stroke on a NOAC, what to do in bleeding patients. And I'll touch on some of those. But I like to start always with a seemingly easy issue, but which I think is not to be underestimated. And Mohammed, if you're still here, you will most likely agree with that. As you know, I just learned that Mohammed is doing his thesis on drug-drug interactions, especially in the field of DOACs. And this is why metabolism is crucial, and one needs to know the metabolism, at least that there are differences with respect to the metabolism. It's summarized in this figure here, and it's also summarized in this table, which I'm sure you've seen in one of the other permutation before. And there are differences between the drugs. I think that's the most important issue. There's no one size fits all NOAC. We have 4 NOACs available, and I think we should take advantage of the fact that we have 4 different drugs available, because they are in certain situations, it may be the one or the other drug may be more useful. Now, it starts already with bioavailability. There are some important differences between the drugs. The Bigetran is 3 to 7% bioavailable, whereas rivaroxaban goes up to 100%. Now, that is only if people take it with food. That's very important. If somebody doesn't eat breakfast, and it needs to be a good breakfast to resorb this well, then they need to take it at a different time point during the day, or they need to be on a different NOAC, because we haven't seen this food dependency with the other substances. Renal clearance, of course, is also a big issue. The Bigetran is on the upper part of the spectrum here. It's over 80% renally cleared. Apixaban is only 27% renally cleared, whereas edoxaban and rivaroxaban are somewhere in between. Now, it's important to memorize, though, or to realize that the dose of edoxaban is reduced by 50%, so it's cut in half if people are below 50 with their creatinine clearance, whereas for rivaroxaban, it's only, in quote unquote, reduced by 25%, right, from 20 to 15 milligrams. So all of these things factor in, and this is ultimately the graph that how we kind of view the use of NOACs in renal disease. Now, for the Bigetran, which is a good drug, as we've seen, it's a very efficacious drug, but we need to be a bit careful, because below 50 milliliters per minute, there is a certain risk that the drug will accumulate. And that's why, especially below 40 milliliters, once you approach 30, we need to be careful with that. Below 30, the Bigetran is contraindicated, in contrast to the TNA inhibitors, which can be given all the way down to 15 milliliters per minute. Now, with that being said, given the data that we have for patients with renal insufficiency from the randomized trials, given the dose reduction criteria, the different kinetics in terms of renal clearance, there may be, and this is also how we write it in the guide, a certain preference for edoxaban or apixaban especially once we reach the situation below 50, below 40, below 30 milliliters per minute creatinine clearance. Now, again, we need to mention that there are no head-to-head comparisons, so we need to be careful with these type of recommendation or this type of advice. But on the other hand, we have the patient sitting in front of us, and we need to make a decision. We need to make a call, and these two actually turned out to be very efficacious and particularly safe, also in these high-risk individuals, and hence this recommendation. Yes, Dennis, please.
Yeah, I think Mohammed is back, and he was going to ask something on some of these points.
All right.
Yeah. Thanks. That's an excellent presentation. Just a quick question about drug-drug interactions. So we're working on this right now and trying to tease some outcomes related to certain cardiovascular medications. Now, one of the proposed recommendations is to consider reduced dose DOACs, even if we don't have like the age and kidney criteria, just to overcome the potential drug interaction. Any thoughts about this?
Yeah, thank you very much. You're actually jumping just 1 or 2 slides ahead of what I was going to say, because you're absolutely right. I think the metabolism part, this is something that we frequently have a little bit of a blind spot for. Now, we all think about, well, if we do think about something, we think about renal function, but we tend to forget metabolism. And there are important differences in the metabolism, especially the hepatic metabolism, right? The Bigetran is not at all CYP3A4 dependent. Edoxaban is only minimally CYP3A4 dependent, whereas there is some dependency for apixaban and rivaroxaban. And this does translate into a different level of possible interactions. Now, CYP3A4 is one. PGP, P-glycoprotein, is the other big player that we need to watch out for. And all of these can lead to an increase or a decrease, which is also important, in the levels of NOACs. And so this is why we have, and this is only one table out of probably 15 or 16 that we have in the guide for different drugs. We've come up with these color-coded tables. And what they tell us is not so much what we should combine and what not, but more what type of increase or decrease in the plasma level we can expect when we give certain co-medications or certain combinations of NOACs plus other medications. And we can see here that some of these do not seem to have any effect at all, DITCH, for example, whereas others are quite substantial, dronedarone, for example, in the case of the dabigatran, or edoxaban. In that context, I should also mention that edoxaban was actually the only NOAC, and also to answer part of your question, Mohammed, the only NOAC which was planned to be dose reduced during the trial. So it was actually mandated to give the reduced dose, 30 milligrams in case of the approved high dose regimen. So people were reduced from 60 milligrams to 30 milligrams if they had a strong PGP inhibitor as a co-medication, such as dronedarone, cyclosporin. In the trial, they also had it for verapamil and others. And it really turned out quite well, in the sense that patients who had dose reduction based on drug-drug interactions had the same outcome as those that did not. So the phase 2 trials, or the phase 2 data that were accumulated beforehand, actually were of some value, in the sense that we chose, I guess, the right drugs to start with to dose reduce according to drug-drug interactions. Now, we do not have those data for the other NOACs available. We have to say that first. Edoxaban was the only one that was dose reduced based on, in the randomized trial, based on drug-drug interactions. However, I guess there is a certain value, and this is one of the next frontiers that we're going into, really, to check NOAC plasma levels in patients with multiple drug-drug interactions, multiple possibly interacting drugs, as well as to put this into an even bigger context, in other high-risk populations that were underrepresented in the large randomized trials. And the idea behind this really is to have to measure these levels, to have a metric to see not so much if they're in the target range, because there is no target range for NOAC plasma levels, really. This has never been prospectively established, like in VKA, but more to check if the plasma levels that you get in these patients are actually in the range of where we usually observe them in the randomized trials. This is the idea behind the plasma level measurements, especially in the context, for example, for drug-drug interactions. Now, we need to be honest with our patients in these situations, right? We do not have any outcome data with that. Let's put edoxaban aside, but for the others, we don't have any outcome data available for that, right? So we do not know, does this really also translate into better outcomes? If we dose reduce, for example, rivaroxaban based on certain drug-drug interactions, then check the plasma level. Plasma levels in range, and so we just keep going with the reduced dose, which is formally in that situation off-label. We don't have any outcome data for that, and we need to tell our patients that. But I do feel that this is the next frontier, and I'm actually quite confident that measuring these steady-state plasma levels, trough and or peak, ideally also, which is even more challenging, will turn out useful. All right.
Thank you.
So, but of course, this brings us to an even bigger topic, I guess, and that is the patients that are a little bit underrepresented in the trials, that are highest risk, and usually the highest risk patients are underrepresented, but nonetheless they do need care. And one of the patients that are frequently felt to be underrepresented are the elderly patients. And I'm saying felt because what we see here is the meta-analysis, a meta-analysis of all the older and younger patients. So here they took the cutoff 75 years versus less than 75 years in the randomized trials. And what you can see here Make a long story short, you have a benefit in terms of efficacy in the younger patients. You have a benefit very consistent across all 4 NOACs in the older patients. And if anything, the point estimate here is even further in the direction of favoring NOACs. So saying that older patients are not good candidates for NOAC therapy because they don't derive the same efficacy, that's probably wrong, because if anything, they derive an even bigger efficacy. It's not to say that we shouldn't treat the younger patients with NOACs, but certainly the older, if anything, it's a reason to be put on a NOAC from an efficacy point of view. Now, from a safety point of view, we again see for the younger patients a pretty homogeneous effect. I guess there are some little bit outliers, but overall pretty homogeneous effect. But in the older patients, you also statistically have a strong heterogeneity between the trials, which goes exactly in the same direction as the one that we had observed in the overall trial population, right? You can see here that there's, in fact, a point estimate for the bigatran and for doxaban is actually on the wrong side of the line of unity, but the confidence intervals overlap. So there's formally a similar risk of major bleeding with these two, but there's in fact a reduction in major bleeding with the apixaban and edoxaban. Now, again, want to mention, this is not direct comparisons. We need to always be careful not to overinterpret this. But again, the patient is sitting in front of us and we need to find a solution for that specific patient. And I think in this regard, these data can be quite useful. Now, the other thing I'd like to draw your attention to here is the number of patients. We're looking at over 24,000 patients that were 75 years and older in these trials. 24,000 patients. Actually, in the ENGAGE-AF trial alone, there were over 3,500 patients 80 years older. So if you combine this with the data that I showed in the beginning of the VKA, now, of course, this was a different era. This was the late 80s, early 1990s. But you could make an argument that we have more data for edoxaban over VKA than we ever had for VKA compared to placebo. Right. So just, I guess the point I'm trying to make here is that we feel sometimes that we should be switching these patients rather to warfarin. The evidence base for NOACs is actually quite good. And actually probably, especially in terms of randomized trial data, even better than with warfarin. So if anything, this is a reason to put these people on one of the NOACs. Now, of course, old age does not always mean frailty. Biological and chronological age do not always match. And this is why we took a look at this specifically in the ENGAGE-AF trial, prospectively, actually. So in the ENGAGE-AF trial, we prospectively identified patients at an increased risk of falling. In every single one of those over 21,000 patients, this was done. And ultimately, we published this a couple of years ago, 5-6 years ago, this subgroup of patients at increased risk of falling versus not at increased risk of falling. It was a sizable group. It was over 900, or pretty much exactly 900 patients included, that were at increased risk of falling, which I think is important because these are the types of patients that are usually excluded from trials. And to make a long story short, the efficacy and the safety of edoxaban was exactly the same, whether you were at increased risk or not at increased risk of falling. But so with edoxaban versus warfarin, and that's already important. But what's even more important is that these patients, because they are frail, they're older, they have comorbidities, of course, their absolute risk of events is higher than those that are not at increased risk of falling. And whenever you have a similar relative risk reduction, if you apply this to a low risk and to a high risk population, your absolute risk reduction will be even bigger in the high risk population, right? And this is exactly how it turned out here, right? Say if you have an absolute risk of 1% per year and you have a 20% relative risk reduction, you reduce that from 1 to 0.8%, which means a 0.2% absolute risk reduction. So number needed to treat of 500. Now, if you take an absolute risk of 10% per year, and you apply that same 20% relative risk reduction to that, you go down to 8% absolute risk reduction, 2% number needed to treat 50. So that means that if you have a situation like we have for edoxaban, where virtually all of the high-risk subgroups pretty much came out the same as the non-high-risk subgroup, very consistent results. It means that if you treat the higher risk population, you'll get an even bigger bang for the buck. It's not to say that the low risk population, low in quote unquote, does not benefit, but it worked out pretty well also in the high risk and with an even bigger absolute risk reduction. And in a larger scheme, actually, there are similar data retrospectively for apixaban in the Aristotle trial, from the Aristotle trial as well. And that's why on a larger scheme, I think it is important to not see old age or frailty, for that matter, as a black and white situation. There are 50 shades of gray in between. Or as we put it here in our EHRA guide, in this inverted traffic light here, really, there are various shades of red, yellow, and green, depending on the degree of frailty, which of course is your Canadian frailty scale that we abused here and referenced for our EHRA guide. And you can see that, I think, for the very terminally ill, the most severely ill patients, probably your net benefit from anticoagulating them is most likely not the highest. But what's more important is that the ones in yellow and certainly in green, those are patients that will benefit. And if anything, they benefit even more than the non-frail patients from being anticoagulated. Because as we know, if these people have a stroke, it usually does not turn out well. Obviously, a stroke is never a good thing. But these patients have an even lower chance of returning back to their baseline when they've had a stroke. And that's why really being frail, of course, within limits, if anything, is an indication and not a contraindication to anticoagulation. Another challenging population that's also at least partially underrepresented in the trials is patients at the extremes of body weights. So very low and very high body weight. Now, the good news is that within the normal range, and we kind of defined this here as 60 to 120 in our guide, just from a body weight perspective, people can be treated with NOACs at their regular doses. Now, once you go below 60, certainly once you go below 50, it becomes a bit more difficult. Edoxaban has body weight less than 60 as a single criterion. So if you have that, your dose is reduced. It's one of the dose reduction criteria also for apixaban. So we figured those two actually do have some randomized data for a reduced dose in this range. So it may be one of the preferred therapies. Once you go below 40 kilograms, data become quite scarce. And the same is true actually in the high body weight population. And this is why we also introduced the concept of plasma level measurements in these types of patients as an option to assess. Now, in the ENGAGE-AF trial, we have the largest database really with plasma level measurements, because this was systematically done. And what's quite interesting is that if you take a look at patients with very low body weight or patients with quite high body weight, both trough and peak edoxaban concentrations or anti-10A activities actually were quite consistent with the normal body weight population. And this may have to do with the larger volume of distribution of edoxaban, which is the largest of the 4 NOACs. But it actually also translated into a similar outcome. So overall, these are actually quite good news, and kind of go into that direction that possibly measuring plasma levels in these the borderline patients that were really not well represented may be an option in the future. Let's skip over this. And this is also mentioned, of course, in your guidelines, that a high BMI, obesity, even morbid obesity, should per se not be a reason not to treat people with DOACs, because there are data indicating that the efficacy and safety is quite good. Of course, the one thing we're afraid of is stroke. The other thing we're afraid of is bleeding. And this is the, well, kind of like the last bigger topic that I want to touch on today, this morning. And this is the scheme that we put up, that also others have put up in a similar way, how to treat bleeding in an NOAC-treated patient. I think the first very important part is to really assess the entire patient and not only jump on whatever bleeds, but really see what are the comorbidities, what is the risk factors, what's the NOAC, what's the dose, how has the patient been over the last couple of days, is there a chance that there is acute renal failure, all of these things. number one. Number two then is to take a look at the type of bleed or the severity of the bleed. If you have a mild bleed, and I'll just blow this up for you so that you can read it well here. If you have a mild bleed, there's usually no big action necessary. We put it in there nevertheless, though, because this is really a great chance to reassess, first of all, if the patient is on the right NOAC, if there's possibly some changes in the medication that we could anticipate to kind of reduce the risk. But secondly, we need to ask our patients actively about this, because these are the type of bleeds that they usually experience. If they experience them, they don't tell us about them, but they stop their NOAC, or they change their regimen, or they go to half a tablet or so. I think we've all experienced that. If we go one step further to the non-life-threatening major bleedings, now these are the types of bleedings where we need to pull out our supportive measures, right? Transfusion, stabilization, transfusion possibly, and definitely to look for the cause of the bleed. Most of the times there's a reason for the bleed, and in many, many situations we can fix it, or at least we can treat it. And sometimes it's lucky in quote unquote. I think we've all diagnosed at least some patients with a cancer just by starting anticoagulation or dual antiplatelet therapy for that matter. So we need to look for the reason for the bleed. There usually is a reason for a bleed, and then treat it accordingly. And then finally, once you come to the life-threatening or the bleeding into critical organs or critical sites type of bleeds, then we need to pull out the big guns. And that means the direct antidotes, the Bigetran. For the Bigetran, of course, that would be iduricizumab. For andexanet, for the 10A inhibitors, it would be andexanet alpha. If we do not have these available, however, then we do know today that also factors work. PCC, APCC actually also works in NOAC-treated patients, possibly with the exemption of intracranial hemorrhage. There is not the most efficacious, but unfortunately for that, we really do not have much available yet. Suffice it to say that fortunately the risk is under NOAC therapy become very, very low. Of course, all of our ED doctors will tell us it's not zero, and that's correct because they see them. But if you take a look at all of the available data, it's really become quite low, that risk of intracranial hemorrhage with the NOACs. Now, I'd like to briefly spend just a minute on the antidotes, because there's a lot of, obviously a lot of interest in this, because ultimately it was the first time that we had an antidote for a plasmatic anticoagulant. Leaveside heparin maybe, but for VKA we didn't have a direct antidote, right? I mean, we had vitamin K, but that takes about a day until it works in full effect. And then we had PCC and APCC, but that's also hardly an antidote. It's a procoagulant, right? So we kind of try and fight fire with fire, but ultimately do not, or with water, I should rather guess, but ultimately with a potential risk, also a prothrombotic risk. So really, this is just as much of a paradigm shift to have antidotes available for all NOACs that are currently available. And of course, iduricizumab was the one that was first available. And I think it's fair to say that iduricizumab is probably as close as you can get to a perfect antidote. I mean, iduricizumab works extremely well. If you give this either to a bleeding patient, and this is from the reverse AD study now, or to a patient with who needs to undergo an emergency surgery, you take out the Bigetran from the equation of that patient immediately. Within minutes after you infuse the drug, you no longer see an effect. You also no longer see free plasma levels. So this works extremely well. If we take a look at the flip side, though, or if we take a look a little bit further in the reverse AD study, you do see that in both groups, so the bleeding as well as those with undergoing emergency surgery, there's a substantial mortality. After 30 days, over 12% of these patients are dead. And after 90 days, almost 19% of these patients are dead. And by the way, these figures look very similar in the andexanet alpha trial. Almost scaringly similar. And this is not because of iduricizumab. Like I said, I think iduricizumab is a very good drug. It's not because, it's in spite of iduricizumab. When under NOAC therapy, you do have a severe bleed, a life-threatening bleed, It's much less common than under VKA, but if it does happen, there is a certain chance that things will not turn out well. And I think this is, from a practical perspective, quite important, because having an antidote available, and no matter which one it is, no matter for which drug it is, I think is good. It's useful to have that available. I would never make it my own decision point. So say, for example, a patient who has a creatinine clearance of 32. I'm taking an extreme example now. 32 milliliters per minute. Formerly would be eligible for dabigatran. I would not give that patient dabigatran just because I have an antidote available, a very good antidote in addition. Because if that patient, for that patient, dabigatran might not be the best drug. And just because I have an antidote, I wouldn't give that drug to this specific patient. There's a risk that that patient will accumulate the drug. There's a risk that that patient will run into a severe bleed. And then we have the data available that even with an antidote, there is a good chance that things will not turn out well. So make it a factor into the overall process, yes, but I would not recommend to make it the only choice, the only factor that decides which NOAC should be given to which patient. Now, final aspect, of course, and also here, I think we can nicely close the loop also to the Canadian guidelines. Drugs don't work in people who don't take them. So we need to do everything to optimize adherence, compliance to drugs, with drugs. And we have chosen this image here, this figure here, to see, to demonstrate that all stakeholders need to be involved in this. Formulations need to be looked at to optimize adherence. Very important. It's not enough to just simply tell the patient, look, you need to take this, otherwise you'll have a stroke. There are other tools and gadgets that we can take advantage of, technological aids. You know, we should not underestimate our patients. They, even if they are a bit older, sometimes, frequently in the AF population, they actually enjoy working with their smartphones and like reminders and things like that. So they're totally apt for that. And of course, this is also a very important topic that's tackled in your guidelines as well as in the ESC guidelines. And I think it's something that's underestimated. We, especially in larger centers, academic centers, and you know, we're in the same boat here, I guess, we frequently feel that they you know, patients should be thankful that we tell them what's best for them and that we prescribe it for them. But in reality, well, they may be, but the story doesn't end there. They need to really know, they need to be engaged, they need to be empowered. This whole concept, I think, of patient engagement empowerment is something that we frequently preach, but we're not really acting accordingly. I think it's very important to get the patient on board, because ultimately what we're doing here is for them. It's not for us, it's for them. Which then brings me to my conclusions. First of all, I think pretty clear NOACs are the standard therapy. Nowadays, there's hardly any good reason around that. We've seen that older age frailty is, if anything, primarily an indication, not a contraindication for anticoagulation. And we have good data for that. Randomized data, observational data. There's really a host of data that essentially all point into the same direction. We do need to individualize therapy. As indicated, there's no one-size-fits-all NOAC, which is challenging. It's already challenging for us. We're dealing with this on a daily basis. It gets even more challenging if we go into clinical, into general medicine, into primary care practices. But I do feel that it is worthwhile investing our time and effort into, because ultimately we will have an impact on our patients' outcomes. I hope that with our EHRA guide, we were able to give some guidance for daily clinical practice, sometimes including situations that are without much evidence. But ultimately, these are the next frontiers. We have the patient in front of us. We need to make a decision, and we need to come up with new data so that hopefully in our next edition, we can revert back onto even more data for our guidance. And with that, I would like to thank you all very much for your attention. Obviously, I'm very happy to tackle any questions. Thanks a lot.
Great. Thanks a lot, Jan. That's fantastic. I've got a few questions that people email me. I'm going to start with Daniela. She's one of our pharmacists in the Schulich cardiology unit, and she teaches me about DOAC and things. Like she has a really clinical question that you would like to ask.
All right.
Hey there, can you hear me okay?
Yes, absolutely.
Great, thanks for the talk. That was great. I actually just see someone else in the chat wrote the same question as one of mine, and it was just about the elder care AF trial. So if you see the low dose doxaban, and if you see it like often in your practice, I'd say we don't. I find Sunnybrook is very much an apixaban hospital, but I think using different docs is important. So yeah, it just, if you see the doxaban 15, we haven't really, but it actually got brought up this week on the ward. So yeah, just wanted your thoughts on that.
Thank you very much indeed. That's a very, very good question, because on a larger scale, it touches on the whole topic of off-label reduced dose or low dose NOAC application. And I think it's a very important trial, but I will take a half a step back and go back to the ENGAGE-AF trial, because there's a lot of confusion also about the ENGAGE-AF trial, especially about the low dose of edoxaban, because the ENGAGE-AF trial, as you know, as most of you know, but was conducted in 3 arms. So we have the warfarin arm, and then we have 2 regimens of edoxaban, a high dose and a low dose. And in the high dose edoxaban regimen arm, everybody got 60 milligrams, except those that qualified for dose reduction. Those received 30 milligrams. So this is the approved arm. But there was an entire third arm, which is the low dose edoxaban regimen arm. And there, everybody received 30 milligrams. And it was dose reduced to 15 milligrams. And this is, by the way, where those 15 milligrams first turned up. And so this arm is not approved for use, actually, I think nowhere in the world. And the reason for that was that in the ENGAGE-AF trial, there was about a 41% increase in ischemic stroke, not overall stroke, but ischemic stroke, as compared to warfarin. And as a result of that, it was not approved. However, if you compare the two directly, the high dose and the low dose arm, and we did that and we published that last year in JACC in April or May, you see that the net outcomes, so the net clinical benefits, are actually the same in both arms, because there is a huge reduction in major bleeding, even more than in the approved high-dose edoxaban regimen arm. And there's actually a reduction in all-cause mortality compared to VKA, a strong reduction in all-cause mortality with the low dose, the unapproved 30/15 edoxaban. So I guess what my message is here, if you brought up apixaban before that, and I think we all agree apixaban is a great drug. It's very efficacious, very safe NOAC. But sometimes we have a feeling that the patient would rather benefit from the 2 × 2.5 apixaban rather than the full dose. So we give the reduced dose off-label. We see that a lot worldwide, actually. It's probably the NOAC which is most prescribed off-label with the reduced dose. And there is a strong but important difference, because they're both off-label, edoxaban and apixaban, in that situation. But for edoxaban, we have an entire arm of a randomized trial that informs us of the outcome of these patients, over 7,000 patients. So, and this is why if I do go off-label, and again, we need to tell our patients that, right? This is off-label. But if I do go off-label on a reduced dose, I would rather do it with edoxaban, because at least I have randomized trial data available for that. That's from the ENGAGE-AF trial alone. And I think this is probably even more relevant to our daily practice than the elder care trial, because coming to the elder care now, I think this was a very daring trial, a very courageous trial, which was, however, only performed in Japan. So this is only Japanese patients. And these were patients that were deemed to be ineligible for NOAC therapy, 80 years and older, renal insufficiency, a chronic NSAID therapy, all of these things that are usually not so nice if we want to treat patients with a NOAC. And these patients were then randomized to either very low dose edoxaban, 15 milligrams, or placebo. So this was a placebo-controlled trial with a NOAC, which is the first and only so far that we have a NOAC compared to placebo, because in other times it was compared to VKA, or in the case of Adherence to aspirin. So here we have a placebo-controlled trial. And the reduction in stroke and systemic embolism with this very low dose of edoxaban in this high-risk population, and that's important because they come from a high baseline risk, was quite dramatic. It was over 4% absolute risk reduction, which really translates into a good number needed to treat. And you buy it at a much lower increase of severe bleedings, which was not even statistically significant, but there was a trend, and you would expect that. You would expect a bit more bleeding if you give a drug that thins the blood, right? So, so ultimately, I think this goes into the same direction of what I was alluding to earlier. I think if we're really in a situation where we feel that patient is just not the good patient for a full dose NOAC, I think both the low dose regimen arm of Engage as well as the elder care do provide some good quality randomized trial data evidence that we can share with our patients, and that we can tell them, look, this is your outcome. At least that's what it would have been in the trials. This is what you can expect. So in terms of patient engagement, again, patient empowerment, I think that's a good way of evidence-based reduced dose NOAC use.
Sounds good. Daniela has one more question. So you go ahead. That's your.
Okay, thanks, Dr. Ko. A question about Afib and PostPCI. So in the Pioneer AF-PCI trial, do you use, like in practice, will you use the Riba-10 and Plavix if they have poor kidney function? Because I'd say we're pretty hesitant on that. We really try and stick with Riba-15 and Plavix, just from, I know there weren't many people in the trial that went to Riba-10, so just wondering what you do with that.
No, that's absolutely correct. Very good point. And I think it's absolutely like that. I mean, the Pioneer trial was the only trial that used the dose of an NOAC that's not approved or that was not tested in a large phase 3 trial. So I'm not saying that rivaroxaban is not a good drug. I think it's also it certainly got its position, and it's a drug that can be of use. If in post-PCI patients, I tend to not use it, because the combination of a dose that had been tested in a large phase 3 trial plus clopidogrel has not been tested prospectively. It was 15 or 10 in case of reduced renal function plus clopidogrel, and that was not tested in Rocket. And that's why I tend to go with one of the 3 others, because there I do know that from an efficacy point of view, I know what I'm exposing my patients to, because this has the whole phase 3 program with exactly that dose in the back. So yeah.
Sounds good. That's perfect. Cam, do you have a quick question as well for Jan? Maybe that's the last question.
Yeah, my question related to the duration of atrial fibrillation that justifies anticoagulation. If it's picked up on a Holter or a pacemaker assessment, 6 minutes, 5 minutes, 2 hours, 24 hours. I know it's under investigation, but just wondering what you do now.
Yes, thank you very much. Also, that we could easily fill another hour with, of course. Fortunately, this is, like you said, under investigation. Dr. Healy obviously is on this with the Artesia trial. We're also on this with the NOAA trial for doxaban. So hopefully we'll have the answer for that device-detected AF threshold soon. Right now, it's pretty much 24 hours on a device. So pacemakers, it's any 12-lead ECG. So if somebody stumbles into our office, we do an ECG and it shows AFib. Even if they're completely asymptomatic, then it counts as AF. And in a Holter ECG, 24, 48 hours, the cutoff is 30 seconds. Although this has never been prospectively validated, right? Somebody once said it's going to be 30 seconds, and that was it. So this was really never, validated. I think, especially in the border zones, and you mentioned the 6 minutes, right? 6 minutes to 24 hours. We include these patients into Artesia and into NOAA if they are of certain risk, because this is precisely where we don't know, and we need to find out. Right now, I think if we do not have the possibility to include these into the trials, I guess the art of medicine also comes into play. We need to check the CHA2DS2-VASc, check where we stand in terms of overall risk, check also where we stand in terms of burden. If somebody on a Holter has 15 seconds runs all over the place, always interrupted by some beats of sinus rhythm, I mean, there's nothing magical about this 30 seconds, right? Need to put this into perspective a little bit, but this is kind of what the current status of a lack of knowledge, I should rather say, is, and what the guidelines recommend.
Thank you.
Great, thanks a lot. So I would like to kind of bring this session to a close. I would like to thank Professor Steffel again for giving us this great talk about DOAC. I think it's what we tend to call it. But if we have any questions, email me, I'll pass it along. But it's been a fantastic education. And for those who celebrate Happy Chinese New Year, it's a year for Tiger. And somebody said it's supposed to be better than last year. But so thanks everybody for coming, and Happy New Year for those who celebrate, and look forward to seeing everybody next week. Thanks a lot. Thanks, Jan, for coming.
Thank you very much again. Thank you very much. Great pleasure.